On the program today, we have Sister Jacinta Lumeze. She is a midwife who will enlighten us on this topic. Do stay tuned. Okay, if you're just joining us, this is the segment where we get to speak with the medical practitioner. And today on the program, we have here Sister Chineye Lumenze. She is a midwife from the Medical Missionaries of Mary congregation. Thank you for joining us on the program today.
Thank you.
All right, today we're talking about complications during childbirth, and we know that there can be complications that can arise before, during, and after childbirth. Can you just let us in on some of those things that can happen?
Okay. Talking about the complications of childbirth. First of all, childbirth, by definition, is the expulsion of the fetus from the birth canal. And every mother, is always happy whenever she thinks about it. And every person's aspiration, a married person, is to become pregnant and to have children. So it's always a thing of joy for the mother. Now, having said that, at times complications arise despite our efforts to make sure that the woman delivers safely. And such complications can either be envisaged or inevitable. So some of the complications are, we have what we call malpresentation. Normally, the fetus inside, faces the maternal back. The head is down, and the head is slightly flexed, so that the vertex, the smaller portion of the head, is able to fit into the birth canal to facilitate the delivery of the baby. Like as you can see in this diagram. That's the presentation.
You can just
the vertex presentation.
We also see it.
Okay, the vertex presentation, and then the head can come out easily, and then the head is completely out, facilitating the shoulder then to come out, and then the entire baby comes out. So any other presentation aside this would cause complication to the mother and to the baby, like breech presentation, buttocks presentation, that is breech, and then the hand presents, or the leg presents, or the face presents. So when any of this happens, the mother can go into exhaustion because she will find it difficult to deliver the baby. And then the assistant, also the person trying to deliver, may try to maneuver and get out the baby, and that can cause trauma to the tissue, soft tissue, the maternal pelvis, the vulva, and then bruises or lacerations on the baby's buttocks or the arm. It could lead to fracture, and then trauma to the muscles and nerves too, that can lead to malformation.
At that point, what's going to be done?
At that point, normally a midwife is supposed to then refer the child, refer the mother to a facility that has an operative theater to intervene and save the mother and the child. Otherwise, both can suffer distress.
So it's at that point that operation comes in.
Yes. If the midwife or the doctor cannot maneuver, if it is breech presentation, but if it is hand, really, they have to do something, cesarean section, or maybe forceps delivery. And at times, in the process of trying to deliver with vacuum, there could be injury to the scalp of the baby or to the mother, leading to bleeding, tear, and infection. And then.
Okay, now how many vaginal examinations are to be done before childbirth, before the baby actually comes out? How many of those examinations, and what kind of examinations aside from vaginal examinations before the baby comes out?
Before the baby comes out, the woman is usually assessed physically to know if she'll be able to deliver vaginally. And then during the active phase of labor, we do vaginal examination to assess the opening of the cervix, because it is normally when it is 10 centimeter open that the woman will then be asked to, give attention to contraction, which helps to push the baby without much effort from the mother, and then the mother pushes, and there's expulsion.
All right. And for a newly expecting mother, at what time is it? What time is right to start going to the hospital, or do you have to sit down at home and wait for labor to start, for labor pains to come up? At what time is appropriate to actually get to the hospital and wait for birth?
During antenatal, the woman is told the signs of labor.
Okay, so when she starts seeing those
signs, she goes to the hospital. Okay. Then there are other complications too, like what we call cephalopelvic disproportion. Here, the baby's head is too big for the birth canal, or the baby is too big to be able to pass through the birth canal. So when that happens, the woman might not be able to deliver on her own. So they would do either vacuum extraction, which in most cases will be inappropriate. So
when
here,
you say vacuum extraction, what
instruments are used to extract the baby, and that can pose trauma to the baby fetal scalp and bruise the mother, causing bleeding, tear, and other complications. So this can also be prevented if the woman attends antenatal care, ultrasound is done, investigations, physical assessment is done to know if the woman's height and the pelvis is adapted for childbirth. Because we have what we call gynecoid pelvis. Okay. This is the gynecoid pelvis for most women. You see it in women who have hips. At times no hips, but the pelvis is adapted for childbirth. And then the man's pelvis is what we call the android pelvis. It's narrower. And then the woman's height too, and her weight.
That's a factor also.
Yes, will determine if this woman should be allowed to try to deliver on her own.
So what height exactly would we say it's okay?
170 centimeter from 140 cm above. A woman of that height could deliver on her own. Okay.
And when you're talking about this now, gynecoid, yes, you mentioned for those who have wide hips. Is it true? I've always heard that women who have wide hips, it's always easier for them to push during labor. How true is that?
Yes, it's possible depending on the kind of pelvis. We have this platypeloid. It's so wide, and this one, is very easy for a woman to deliver. A woman with this kind of pelvis. Okay. It's very roomy. And the baby can just pass through when she's not even ready to deliver the baby.
Oh, really? That's interesting.
Yeah, but this is the pelvis that most women have. That's adapted for childbirth, because the coccyx, this bone here, can give way easily for the baby to pass.
So it doesn't matter if you're slim or on the big side?
No. If you can, a slim person can have this pelvis.
Okay, now as a midwife, can we look at your worst case scenario in helping people put to bed? What has been what's the worst case scenario now in childbirth?
Most times it's usually the cephalopelvic disproportion. When that happens, the woman cannot push, or when there is no descent at all. No contraction.
No contraction.
When there's no contraction, the baby is hanging up. It's not coming down. And when it exceeds 24 hours, the woman is already exhausted. The child is in distress. So we refer. We can't do anything. And the cesarean section becomes inevitable.
Okay. What's the normal time for labor? When we say it's the person has stayed for too long during labor, what's the longest time, and
it exceeds 24 hours.
24 hours. Okay.
Yes, there should be another intervention. The woman cannot just keep pushing and pushing and pushing.
Okay. And then what's the shortest time? Like
within 24 hours.
Within 24 hours. Okay, nothing less than within 24 hours.
The woman should, except she started laboring at home, because most multiparous, like women who have delivered previously, they know when they are going to deliver. They're used to it. So when it's time, maybe they just come. By the time they come, the cervix is already 8 cm open. Maybe within 3 hours, it's 10 cm open, and they can deliver.
Okay. What can a woman do to avoid placenta infection for the baby? Is there anything like any case like that?
Yeah.
Infection of the placenta or something like
yes, there could be if the woman is infected with sexually transmitted infection,
Okay.
like HIV, hepatitis, all those infections can affect the baby, because the placenta is a channel through which the baby feeds and gets the nutrition, blood, oxygen, and all. So during antenatal, there are tests that we have to do on the woman.
Okay.
Venereal disease test, hepatitis, HIV, blood group, and at times malaria too, syphilis test, to make sure that the woman is fine. And then ultrasound to know the position of the placenta, because some placenta can be low-lying and can be very close to the opening of the cervix, so that if the woman is in labor, before she even goes into active labor, she has started bleeding.
Okay.
And then the baby will suffer what we call hypoxia, loss of oxygen, and will be in distress, and that may lead to fetal death.
All right, finally, before I let you go, what would be your last advice to women, expectant mothers, or women who are almost due for labor? What are those things? Are there do's and don'ts?
Yes.
Okay.
My advice to women, especially the pregnant women, is to always go for antenatal as soon as they know that they are pregnant. 1 month, 2 months pregnant, they should begin the antenatal. Then they should also carry out those tests and investigations that are recommended for pregnant women, especially the ultrasound, which helps us to know the fluid, the amniotic fluid volume, and then the size of the baby, the weight of the baby, and then the position
of the baby,
placenta, and just it helps us to know the progress of the pregnancy and how the baby is doing.
All right. Thank you very, very much for coming on the program today. Well, we've been talking to Sister Chinenye Lumente. She is a midwife from the Medical Missionaries of Mary Congregation, and we've been talking complications during childbirth. Thank you for staying with us on this segment. Let's Talk Health continues right after now.